Okay, hi everybody. I'm still getting used to talking to a screen with a little box of my image in the corner, but I want to thank you all for coming tonight to this inaugural event and hopefully one of many future similar events. This is a combined meeting between the NYACP and which is the New York chapter of the American College of Physicians, and MAGS, which is the Metropolitan Area Geriatric Society. We originally planned this meeting for last March as the first meeting of MAGS outside of Manhattan. And as we all know, everything stopped in March, but we're glad that we're able to do it now this year. And if anything, we were able to expand it through Zoom. So we're very, very grateful that everybody is here. For those of you that are members of MAGS, welcome to the NYACP. It's a very active chapter for internists and their subspecialties. And for those of you not familiar with MAGS, it's the Metropolitan Area Geriatric Society. It's the regional affiliation of the American Geriatric Society. And if you are not a member of either, I would encourage you to consider both. And if you're a member of one, please consider joining the other. So in terms of the disclosures, none of the planners for this educational activity have any relevant financial relationships to disclose. Dr. Alan Steinberg, who is our speaker for today, has no relevant financial relationships to disclose. And the members of the NYACP College Education Content Validation Committee, they should come up with an acronym for that. There's probably too many C's to do that. Who oversight the chapter education programs. This is a list of their relevant disclosures. So we are also delighted as having this program be with NYACP that we could provide CME credit. A link with instructions for claiming CME will be provided to the webinar attendees by email immediately following the conclusion of this activity. You are eligible for one AMA PRA category CME by participating today. You can find lots of more ACP resources and information through their online learning center. And you can find out more about the NYACP through their website, which is nyacp.org, and about MAGS with magsnewyork.org. I would also like to, I'll go back to this slide just to give you a little bit more information. Some housekeeping notes. The webinar today has a chat and a Q&A feature. So the chat, I believe you can chat with each other, probably comments like, wow, this is so great. I'm so glad I'm here. And you could chat with the group like, wow, this is so great. I'm so glad I'm here. But we also have a Q&A feature. And if you have any questions, like whatever it might be about the great presentation you're about to hear, please share them through the Q&A. Everybody who's here is muted except for the speakers while they're speaking. I will be collecting the questions throughout the presentation, and then we will review them with Dr. Steinberg at the end. So please, as you have your questions, please share them through the Q&A, and then we will address them at the end. Your questions are definitely important, and we don't want to lose them if they're sent through the chat and we get lost with the different chats. So I would now like to introduce Dr. Alan Steinberg. I don't even know if you could see him on the screen. You probably only see me, so it's like a big reveal. So Dr. Steinberg, I can see him. So I'm smiling at him and he's smiling at me, and hopefully everyone out there is smiling too. So Dr. Steinberg is a geriatric psychiatrist who practices in Long Island, New York. He trains at Hopkins Hospital and did geriatric psychiatry fellowship at Cornell New York Hospital. And he co-founded and directed the Long Island Alzheimer's Disease Assistance Center. He's currently the principal psychiatrist in East End Neuropsychiatry. So for the Manhattan people, that's Suffolk County, which is a multidisciplinary community-based academic and teaching practice in Centereach. And he also serves as the primary training site in geriatric psychiatry for the SUNY Stony Brook trainees in psychiatry and in geriatric medicine. Dr. Steinberg has served as a psychiatric counsel to Suffolk County Board of Social Services, APS, and currently serves on the Suffolk County Elder Abuse Multidisciplinary Team. He's been active in the American Association for Geriatric Psychiatry and chaired the annual meeting in 2000. He's received rewards and recognition for his work from multiple organizations, including the Long Island Alzheimer's Foundation, I had the pleasure of learning from Dr. Steinberg when I was a resident, and my husband, who's a geriatric psychiatrist, also learned from Dr. Steinberg and rotated with him. And Dr. Steinberg used to say that he was, the best geriatric psychiatrist in Long Island, but now he changed it to Suffolk so as to not insult my husband. But we're very, very grateful for this presentation. You'll see Dr. Steinberg is a very dynamic, engaging speaker, no pressure, and we're really glad that you're here. All right, so I am going to stop sharing and mute myself, which those of you who know me is a big deal.
Okay, and I am going to begin. So we shall do this. And are you able to see things yet?
Not yet. You need to share your screen.
Now I have to share my screen. I'm sorry. Give me 1 second, please. We have to share screen and do that. And now we have to do play. How is that? Is that better?
I don't see it. I don't know.
It now?
Nope.
Not yet. How interesting. Okay, let's do that.
Oh, wait. You got it. Okay. Just and go back to the first slide.
All right. Okay, we're all kind of.
Everyone close your eyes till he goes back. There you go. All right.
Welcome everybody. Thank you so much for being here and giving of your very precious time to this talk. I wanted to start by thanking Dr. Lester, by thanking NYACP and MAGS, by thanking Ms. Allen and Ms. Panisi for pulling this together and giving me this opportunity to speak with all of you. I never used to say I'm the best geriatric psychiatrist. I said I was the only one. So therefore,
I just assumed you were the best. My bad. Sorry.
Very much. So we're going to talk about some challenging problems that all of you undoubtedly face. I do like to say that if you're an internist, and certainly if you're a geriatrician, you're a geriatric psychiatrist, whether you like it or not, because the growth of the elderly population is, of course, enormous. The demographic imperative is huge, and not that many people are going into our field. So as the frontline folks who care for older folks, you will be managing or asked to manage and address geriatric psychiatry issues. People who know me know that I like to talk about basics before we get into things. We will be talking about agitation and what we call the non-cognitive behavioral and psychiatric symptoms. But I am often asked by my colleagues, Alan, what would you do for agitation? And I step back and I say, well, we have to figure out what we mean by that word. So we have to first start and say, what are we treating when we are calling something agitation or identifying a behavioral problem? A typical unfortunate fallback position is something that you all have seen undoubtedly. Oh, she is behaving that way because she's 97 years old. I just want to caution you, of course, to not fall into that attempted explanation. Age itself is not the cause of a particular behavior. The use of the term agitation is, of course, ubiquitous. We've all received phone calls and pleas for help from any number of sources, family members, nursing home staff, colleagues, because Mrs. Schwartz is agitated. I don't know what that means when a person says to me that so-and-so is agitated. So I just we'll step back and talk a little bit about that. I also have a particular bugaboo about language and the way we describe people. For instance, we often will say somebody's hypertensive, somebody's diabetic, somebody's schizophrenic, somebody's demented, which of course I truly dislike. So it's an adjective, and I'd like there to be a shift amongst all of us if possible. Person has diabetes, they're not diabetic, they have hypertension, they're not hypertensive. And by the way, they're demonstrating agitation, they are not agitated. So these terms are consequential because when we hear that somebody is, for instance, agitated, we will then act on that report. And unless we know what is causing the agitation, which of course follows the step of identifying what the word agitation means, we will take action. We will prescribe medications most commonly. And it's really important to know what we are treating and what is being labeled for us by those people we are using as informants. We're only as good as the methods we use and the information we receive. And this is unfortunately a flaw that in my field we struggle with. But what it means at its root is that much of our time, my time in particular, my colleagues' time, is spent educating the informants. We may spend more time with the caregivers, the family members, the nurses' aides, defining terminology for them and getting them to objectify symptomatology for us so that we can make better decisions. So educating our informants, which could, of course, be a wide gamut of folks, is very, very important, and of course leads us to provide better care. So I can't see by a show of hands, but how many of you have heard, my wife is very agitated. He's agitated all the time. Her agitation is a real problem. He's disruptive to the whole unit. He's grabbing the staff. His nights are awful. He's agitated. So feel free to contribute examples through Dr. Lester, but I'm sure these will represent just some examples. And you will be on the receiving end of a request to do something about that. And that's really the bind that we're in. So what you need to ask about, or the things that I find are very, very important to drill into, are things like, when you use the word agitation, are you talking about, well, you can't do this for me now, but Y, B, H, K, S, P, and C. You should all know what those are. They're yelling, biting, hitting, kicking, spitting, and cursing. Those are all elements that could be components of what is meant by agitation. And maybe there are other things that they are referring to when they use the word. You want to find out about the intensity of this agitation, the frequency of it. Is there a pattern? It's more likely in the morning, the afternoon, the evening, overnight. The duration of it, does it go on for 5 minutes? Is it a 30-second event? It's a quick on, a quick off. And by the way, is it physical? And by physical, we can drill in a little more and say there's resistiveness or there's combativeness. And when we talk about that, we say it could be to self, it could be to others, or it could be to objects in their environment, physical agitation. Is it verbal? Is it yelling? And if it's yelling, again, is it a quick, loud outburst, or is it a slow, simmering, escalating, and then leading to explosiveness, verbal outburst? Again, it's important to understand who are the informants, because as a simple example, in a nursing home setting, you'll have a nurse's aide who will report that Mrs. Jones is agitated. What do you mean? Well, she's hitting me. Okay, that's interesting. So I want to know, what do you mean by hitting? Well, is she slapping you or is she punching you? Those are actually very distinct. They may not make that much of a difference to the hittee, but they do make a difference to us, because if we're going to intervene through whatever means, whether it's medical or environmental or behavioral, there's a big difference between being slapped and being punched. And there's an improvement when you progress from punching to slapping. Again, the person receiving the slap may not see it as so, but it really truly is an improvement. So we want them to be sensitized to those degrees of intensity, of frequency, of duration. We want to know if it's redirectable and how long. I saw a patient today. They were redirectable for about 10 to 15 seconds. It was pretty as close to unrelenting as you could possibly get. And of course, the family were exhausted. They would redirect their mom, and literally, before they turned around, she was back at it again. I saw another person today who it's just in the mornings. They start to scream and it lasts for about an hour and then it goes away. Another person that I saw yesterday, they put music on and music soothes them and redirects them. So there are many different approaches, of course, but the information we really want to learn about, because it will determine our response, are these elements. Whether it's physical, whether it's verbal, whether it's to self, to others, to objects, and intensity, frequency, and duration. So what the heck is the definition of agitation? So of course you're familiar with, especially in this day and age, political and social agitation. We're referring to, we call it psychomotor agitation, or PMA. Psychomotor agitation is the psychological and physical restlessness. It can be manifested in different ways by pacing, hand-wringing, other activities. Sometimes it can be a symptom of severe depression, of schizophrenia, of dementia, of any psychiatric disorder, including delirium, including dementia, including depression. And so it's non-specific. And that's why it's so very important to understand what is the underlying syndrome leading to the symptom of agitation. So it can be very complicated because at times, especially in older folks, we're going to have to deal with multiple simultaneous causes. An older woman that I saw today was acutely different. She had dropped off a cliff, was what the family said. She was unrelentingly screaming, and then she would play possum, not lethargic, but she would just shut out the world. She was alert, but then she'd come to and start screaming again. And this was actually different from her previous level of agitation or behavior. And of course, my first thought is, what's new? What's going on with her? What could be contributing? And we have to identify the underlying cause. Theirs is, the people who are suffering this, both the patient and the family member, theirs is, can't you do something to quiet her down? It's distressing, it's awful, it's painful to observe. She's in agony. Just give her something. Will you raise this medicine? And my answer, which of course is often received with skepticism and challenge, and it'll be your answer too, is, well, we have to figure out what's happened to her. And of course, we look at all of the potential contributants to a change in mental status, which are similar to the same reversible causes of dementia that you're all very familiar with. There's 60 to 100 of them. I obviously won't bore you with a list of all of them, but suffice it to say, I drive internists crazy by getting urine cultures. It seems to be one of the most common causes of a change in mental status, but it could be come the nicer weather, mild dehydration, mild elevation in BUN, mild anemia. Often my colleagues in internal medicine will say to me, well, we see people with BUNs of 75 all the time and they don't have a change in mental status. And I say, yes, but you're now dealing with a 90-year-old who's on 15 different medicines, who has a baseline already of a fragile, damaged brain with dementia. And so a BUN of 35 might be enough, together with the Benadryl that their husband gave them last night for whatever sleeping reasons, to tip them off of that ledge, that very fragile ledge that they are on. So first up for me are things like UTIs, electrolyte abnormalities, infections, dehydration, etc. And the next is, of course, we look at medicines that they may be on. And I'm sure you're very familiar with the big offenders. We look at it from a side effect point of view. So anything that's sedative, antihistaminic, anticholinergic has potential to contribute to agitation, to confusion, and not just an obvious case of delirium where you have severe lethargy and then it's obvious. It can be very, very subtle. There are medications that have atropine-like equivalents, so they can contribute to confusion. And these aren't the big ones that we're familiar with, but even things like some of the nonsteroidals have some atropine-like activity. Even digoxin can do that, not just toxic levels, even low levels, but remember, our patients might be on an average of 10 to 15 different medications at their age, and so there's a cumulative effect. It's interesting, I saw an 85-year-old also today, and she was on no medicines, and I wanted to write her up. I thought that was reportable. You know, it's so common for us to see folks who are on multiple medications, and these things do add up. And then, of course, there's the challenge we face with environmental difficulties, changes. These things can be subtle, below the radar of family members to report. But one of the side effects of Zoom, interestingly, is that being able now to do home visits, actually without the risk of getting scabies or lice, it has been an amazing boon, because I've been able to observe family members coming and going into the kitchen, the phone is ringing, the dog is barking, and all of this is happening and creating what to me would be a cacophony of stimulation, which to the person with dementia is really assaultive. To a lot of people, the family members, they didn't even hear the phone ring. It wasn't even on their radar. And so this gives us that opportunity to look at environmental features. There'll be 3 or 4 family members over talking each other right in front of the person with the memory problems. And then the person might get more agitated. So we want to look at all of those factors, including, of course, as I mentioned, delirium. Delirium is protean in its manifestations. I just want to gently remind you of that in my field, when there's a change in mental status of any kind, I feel that they have to prove to me they don't have delirium. Delirium can cause any number of psychiatric symptoms, including, of course, agitation. Depression is not talked about that often as a cause of agitation, but it often will. And people will miss the diagnosis of depression because all that will be seen is the agitation, whether it's emotional incontinence with quick lability, crying, sobbing, screaming, yelling. Irritability is a sign of is often labeled agitation. Irritability, short-temperedness is irritability, can all be caused by underlying mood-related symptoms. So that's an important syndrome to not forget. So we have, on top of dementia, the third D of geriatric psychiatry, of course, we have delirium, which is an ever-present concern, and mood-related disorders can cause agitation. When we talk about the prevalence of this, it's a huge problem. And again, for me, this is our daily work. This is what we do. It's normal in a sense. People come to us for these problems. I rarely am referred a patient who's, a pleasantly confused 80-year-old person. They're being referred because of exactly these behavioral and psychological symptoms in dementia, but they're going to come across your path and through your offices far more frequently than they will mine. There are some studies, though, that tell us how common this is. 60% of community residing residents. Looking at long-term care, basically when I was taught at Hopkins about nursing home psychiatry, and back then this was really pioneering to have psychiatry go into nursing homes. We were taught that nursing home, this is Marshall Folstein used to say, nursing homes are tertiary care psychiatric institutions. And he had a good reason to say that. And the reason is because, firstly, what's the definition of a psychiatric disorder? Which, again, back to terminology. When I ask my colleagues in psychiatry, what's the definition of a psychiatric disorder? People look at me dumbfoundedly. We would not ask a cardiologist what's the definition of a cardiological disorder. Psychiatrists themselves thumper over this. What I was taught was that it's any disorder that affects your thoughts, emotions, and/or behavior. Now you can argue, well, that's life. And to some extent, you're right. But when we look at nursing homes, at least 94% of nursing homes have psychiatric, for nursing home residents have psychiatric disorders. And at least 80% of them have these behavioral and psychiatric symptoms. So you're going into a setting, those of you who go into long-term care settings, where until proven otherwise, you're dealing with patients with psychiatric symptoms or disorders, if you prefer. And most of them, unfortunately, have dementia. So this is the symptoms superimposed. And the cognitive symptoms are not really the issue. The issue is that they are yelling, biting, hitting, kicking, spitting, cursing. They are labeled, which again, words I hate, labeled as violent. They are labeled as resistive. They are labeled as refusing. And back in the old days, I don't know the age spread of our audience, but some of you, of course, will remember the days when nurses would write, when they'd hand out the medicines, and they would write on the sheet of paper an R with a circle next to the medicine, and you all know that meant refused. And I would come along and I would write a big circle, and they go, "What are you doing?" I say, "It shouldn't have an R in there. It should say IWATGTMIT." And they would look at me and go, what are you talking about? The circle should say, I, the nurse, was not able to get the medicine into them. And that's a reflection of a different perspective. They don't have the capacity to refuse. They may not have the capacity to consent. They may assent, and that's a whole philosophical discussion, but they don't have the capacity to refuse because they don't appreciate the reason why they're being approached in whatever fashion, sometimes imperiously, sometimes in a rush by a nurse who's got 15 other people they have to manage, and being told, here, take this, and they say no, because that's the word we can all fall back on from an earlier age, and then they get a little R next to their name. So it's really, really important to re-educate staff about that as well, that the burden of responsibility for treatment is on the staff. These people have been entrusted to their care, and it's a duty and obligation for them, and for them to fall back on, oh, well, they refused, or they have a right to refuse, is somewhat simplistic. The answer you should say, or the question you should say to them is, well, do they have the capacity to refuse? Do they have the capacity to exercise that right? And that's really the important issue. When you have 80% to 95% of the patients have dementia, right away, at least a large chunk of them, not all of them, of course, but a large chunk of them will have a diminution in their capacity to appreciate what's being done for them. So these symptoms are a huge problem, and they are very, very draining. They're draining on the caregivers in nursing homes. They're draining on family members who are, again, at the end of their ropes, and it leads to earlier long-term care placement. They lead to hospitalizations, of course, because agitation from a UTI may be the first symptom. The UTI is missed, and then, of course, they get septic or they develop more obvious symptoms. They end up in the hospital. As we all know, if it's from delirium, delirium is not a good marker. It's a marker of frailty, and the rates of people who have passed away with similar illnesses who had delirium a year later is much, much greater than those who did not have delirium. So there's excess morbidity and mortality associated with these symptoms in the community and in long-term care, and associated with misdiagnosis of underlying causes of the agitation, and also, unfortunately, some of the treatments that are recommended. Getting back to my big bugaboo about definitions, we already talked about the definition of a psychiatric disorder. Again, I would poll all of you just for the fun of it, if I could, and I would say, please tell me, what is the definition of an hallucination? And by the way, to my colleagues in psychiatry, I would ask this, and I would get 15 different answers, just so you're not feeling uncomfortable. And as well, if I ask what is the definition of a delusion, I would get 15 different answers. And that's not acceptable, of course, because if we are told by relative lay people or caregivers, mom is hallucinating or dad is delusional. The response that we have is to accept that, oh, those are symptoms of psychosis, and we give antipsychotic medications for those symptoms. So once again, just like with agitation, we want to drill into, are they using that word appropriately? So the definition for me of hallucination is a perception in the absence of a stimulus. So again, poor Mrs. Schwartz, who's in the nursing home, who's sitting at the nursing home station, and there's a loudspeaker over her head, and she has dementia, and there's an announcement overhead that says, Dr. So-and-so, call home, and she goes to the nurse's aide who's passing by, oh, they're talking about me. The nurse's aide will say to the nurse, who will then say to the doctor or the nurse practitioner, oh, she's hallucinating. And that'll be the end of that inquiry, when in fact that's not hallucinatory at all and not really requiring antipsychotic medications. A delusion, the definition of delusion is a firmly held, fixed, false, idiosyncratic idea. So by idiosyncratic, and that's the kicker, it has to be unique to that individual. So most people will come up with the idea that it's false. That's of course true. That you can't shake it. That's of course true. But it really has to be unique and bizarrely eccentric to the individual. At another time, we can get into a discussion of whether the concept of mass delusions is an oxymoron, because by definition, it should be. By what I just told you, we really don't understand the construct of mass delusions. There was something called tulip mania that happened in the Netherlands back in, don't quote me on this, even though we're being recorded, I think in the 1600s. There are examples of mass hysteria in school, in high school systems in certain places where everybody has caught a certain illness, and nobody really knows quite where to place that. But the true definition of a delusion is a firmly held, false, fixed, idiosyncratic belief. And it's important to get the cultural background too, because we're dealing with people from multiple backgrounds. And so I need a community to say to me, well, we believe in roots. For instance, in the South, there's something called roots, where they mix up these roots-like substances and they can then cast a hex on somebody. They may say, we believe in roots, but what mom is talking about, there's something wrong about that. That's not the right thing. That's not roots. Or people who believe in let's say from Haiti, there used to be people who believed in certain kinds of voodoo incantations. I would have their family members and people from their community define for me whether the ideas that to me might seem very odd, by the way, of course, we're from a different background and culture, are fitting the normative values of their community. So it's got to be unique to them. And so it's important when you have dementia patients to realize that misidentification syndromes, illusions, misperceptions are very, very common. Many of our people have auditory and visual difficulties, so they will very quickly misperceive stimuli. They may over-personalize stimuli. They see two people talking with each other, and they kind of, oh, they're talking about me. And again, they'll be labeled very, very, very quickly as having psychotic symptoms when in fact it may not be. Now, this is again very common. Folks with Alzheimer's, folks with Lewy body, folks with vascular dementia very often have misidentification syndromes. The numbers that have true hallucinations and delusions is higher. There is a more rare syndrome called Charles-Bonnet syndrome, not that common, but often seen in folks with visual impairments. They have actually unique hallucinations. Their hallucinations are very well formed and they're very pleasing. They enjoy what they see. They often will see circus characters floating in front of their eyes. They'll see naked people dancing. They are not frightened by them. They will identify it as their eyes, often, not always, their eyes playing tricks on them. The decision whether or not to treat, in my experience, whether it's from Charles-Bonnet or whether it's just hallucinations or delusions, from dementia itself, not from delirium, not from depression. The decision may be based on how distressing the symptoms are. So the symptoms may be distressing to the caregiver, to the son or the daughter who sees that, dad is having visitors every day in the home, and is not disturbed by it at all, but the family member is very disturbed by it. So to me, also the pure existence of a symptom doesn't necessitate treatment with medication. So unfortunately, obviously, a huge number of folks with dementia at some point are going to have all of these symptoms that you see on this slide. Verbal agitation, and now you know how to drill into what that actually means. They're going to have intrusiveness. They're going to have pacing, which is, of course, different than wandering. So it's important to ask of the staff, are they moving with intensity, with drivenness, versus just comfortably wandering around? Physical aggression, again, is it to self, to objects, to others? Resistiveness to personal care, they may hunker down, that's resistiveness, or combativeness. PMA is the psychomotor agitation, and of course, sleep changes. Sexual behaviors are for me, uniquely challenging because they are often evocative to the receiver. To me, though, I like to ask people to step back from it and see them just as one more example of a frontal lobe dysfunction, of impulse control, and not that they shouldn't be as evocative as they are. Unfortunately, that's difficult to explain to a nurse's aide who's getting touched in a place that we would say would not be acceptable. Note that I did not use the word inappropriate because it's pejorative. It is socially considered inappropriate, but the intent, in my experience, is really key. When you have a person with dementia, it would be wrong to label them, as they often are, as they're labeled as sexual predators, they're labeled as sex offenders. If they are merely an older person with dementia who's disinhibited and they reach out and they grab somebody and they grab them in the wrong place. But it's very, very common. Again, you will be receiving the information from a person who has been unfortunately offended by the behavior. So it's important to process exactly what happened, the when, the where, the circumstances. So you have to train the caregivers. You have to get them to describe in as colorful and descriptive terms as possible the circumstances. What did they observe? When did they occur? Where did they arise? I took care of a patient in a nursing home. To me, it was a pathetic, sad story. And he had a subcortical dementia, which is not uncommon in Parkinson's disease, which is different than cortical dementia. With subcortical, you have more apathy, lack of initiative, lack of motivation, and he had affective symptoms of depression. And of course, he had a resting tremor. And we had a nurse who, I guess, must have had issues because when she went in to see him, his resting tremor was but it was unfortunately under the blanket, and it was around his pelvic area. And she ran out and created a huge scene that he was acting out sexually, and did this for her, and he got this big scarlet letter on his forehead as a result, and a big investigation had to occur about sexual abuse, and he had to receive education about appropriate behaviors. He was totally ashamed and mortified that it would even have been considered that. It was nothing like that at all. So lots of things are in the eye of the beholder, and it's important to process the circumstances. And that gets to the issue of investigating. We describe it, then we investigate it, the related factors. What are their medical illnesses? What medications are they on? What new medical events have occurred? Have they been in any way sensory deprived? Whether or not they have a past psychiatric history, sadly, I found in my experience is often used more to be a bias than a help. And by the way, so too, I guess, parenthetically, is the issue of age, which we've all been taught right from the get-go when we write our notes to say, I was asked to see this blank year old so-and-so, this 90-year-old so-and-so. To me, that does nothing but hurt our assessment of an individual, and it should really be, quite frankly, irrelevant. We've all had people who are in their 50s who are in far worse shape than some people we've seen who are in their 90s. So be mindful of that bias as well. And of course, the communication issues. If a person is approached a certain way, nurses are very, very busy. Nurses' aides are very much overwhelmed. Daughters and sons who are caregivers are juggling 15 things. Often it's how things are said to a person, not what is said. I often like to convey that elicits a response. I use the example of if you say, with a nasty face, I love you, they will respond to the nasty face. And if you say with a smile, I think you're ugly or I don't like you, they will respond to the smile. So it's how things are said, but people don't leave their frustrations and baggage at the door when they come into the room, unfortunately. So we want to educate people about that. And the same is true as, of course, any environmental change can upset the apple cart, whether it's a change in furniture or a room change or a change in a roommate. Unfortunately, or fortunately, we go through even daylight savings time creates changes in our patients' circadian rhythms. The sundowning phenomenon, which is really an endogenous form of delirium. Of course, we see that as twilight approaches, and daylight savings time will affect that. We want to create a model of collaboration, a team approach. Most of you in internal medicine and geriatrics are of course familiar with this. We can't work in isolation. We rely on all of our colleagues from other professional fields as well as our lay colleagues to provide us not just with information, but interventions. I provide people with resources to read, with phone calls, with day programs, with books, so that they are, everything is reinforced. I give them YouTube links for videos so they can watch ideas over and over. And then afterwards, when we do a follow-up, we basically come back and we say, not talking about medicine at this point, but okay, so did you try to approach the person really from their side instead of opposite them? Because the person may have had agitation or aggression before, and maybe because they are a big man, the cavalry will typically be called to change their adult brief. Well, bringing in the cavalry itself might elicit the agitation. And when I say, well, I only want one of you to go in and I want you to sit on the bed next to him, not be opposed to him, they look at me like I am recommending something absolutely out of this world that will get them hurt, when in fact it doesn't. It's more soothing than having 6 people essentially assault a person. So we evaluate, did you try that? Did you try it at a different time of the day? I have been involved in a program actually in Tennessee, which was the development of a dementia unit, which was truly remarkable. I don't think it would ever be allowed to be developed in New York, unfortunately, but it was a unit that was designed like a donut. So the center is an open garden and the outside is a ring. And the ring it's all connected like a space station. And there were 4 hubs in the ring with different themes. One was music, one was art, one was history, one was horticulture, gardening. And they had behaviorists in each wing constantly intervening with the nurses' aides in real time. Maybe you should have approached it this way. Try saying it this way. The lighting was all subdued. They had no locks on any doors. They couldn't see from where the staff came and went. So they never saw people leaving. The door to the inner part of the donut the doors were always open so they could wander. They can go in and out of the garden whenever they wanted. And so environmental architecture makes a huge difference. And unfortunately, we're not as proactive in developing architectural environmental approaches as we should. I hope that day will come. I think it would have been challenging in New York State because in this particular unit, they really didn't care if they wore different socks on a certain day. People came and went. They realized they had dementia. They might go into another person's room. They might end up in somebody else's bed. It might be okay. The family members all understood this. And actually, as a result, the agitation and the use of medications was significantly lower. They also had, interestingly, animals that were bred, puppies, dogs that were bred on that unit to be therapy dogs, and that was their home. So we know that animals and children have an amazing effect on bringing life to folks with dementia. And to the degree that it's possible to encourage that in the programs where you're working, go for it. So what we want to do is whenever I give a talk like this, I basically say agitation or anything that represents a change in behavior should spark a search for the underlying cause. Identify it, describe it, define it, and then start your search for reversible etiologies. We already talked about urinary tract infections, but again, it could be the whole gamut. It could be, sadly, the oxybutynin that was started last week. It could be the anticholinergic medication. I found people on hyoscamine. Why did they put them on hyoscamine? Because they had a little bit of excess salivation. Yes, but now they're much more confused. They have delirium and they have a lot of agitation. And is it really, why would you give a purely anticholinergic medicine? And then if we've ruled all of that out, if time and the severity allow, my practice pattern in terms of managing these changes in behavior is to give an empirical trial of an antidepressant. It's not because we're necessarily seeing symptoms of depression. It's because in my experience, many of these symptoms of agitation or behavioral constellations respond to antidepressants. Does that mean in retrospect, oh, I guess they had depression? No, of course not. There are many reasons that antidepressants might be effective, and most of them we don't know. But they are safer, and I ask myself, would I prefer to be on Haldol or Prozac? I would rather be on Prozac any day of the week. So the challenge is, of course, they take 4 to 8 weeks to work. So again, I mentioned, if severity and time allow, if circumstances and environment allow. And nowadays, when I started, of course, nortriptyline was God's gift to us. It's a fantastic antidepressant. You know, it's a tricyclic. It's got blood levels that are correlated with efficacy, certainly when it comes to depression. The tricyclics have become more challenging because the SSRIs have moved to the forefront. And the SSRIs are all probably equally good. I've also had success with other other antidepressants from other families like mirtazapine and Remeron. The general principle in anybody of a certain age, and I don't even know what geriatrics means anymore, by the way. So I think it's the definition of geriatrics. Anybody who's a year older than me, I think, is the definition of geriatrics. And so when 15 to 20,000 people are turning 65 and going on Medicare every single day in this country, and I see a 65, 70-year-old, that's an adolescent, because the average age of my population is probably 85 to 90. So, you know, the whole definition of geriatrics is changing, but the principle is still the same. As we get older, we do become more sensitive, and we do respond to what would be considered maybe subtherapeutic doses of medicine. So the principle is always start low, go slowly. And just using as an example, escitalopram, it can be 5, sertraline can be 12.5, mirtazapine can be 3.75 to 7.5 milligrams. Now, if that choice does not work, or there are reasons to avoid that, often for these syndromes, I will try a mood stabilizer, not because I think they have bipolar disorder. Again, and in the pantheon of choices, which includes carbamazepine, lamotrigine, it includes lithium, I tend to prefer divalproex or Depakote. And again, we're talking starting low, going slowly. 125 milligrams I give at bedtime because I find that it can be a little sedating. We monitor their ALT, their platelets, their blood levels, but we're not treating them based on the blood level. We're using it just as an indicator of risk of toxicity, not because of a seizure thing. So you should expect, by the way, when you start, if you start divalproex at 125, you're going to get a call from LabCorp in a week that there's an alert that there's a danger alert, that they're way below therapeutic, and of course you expect that. There's a newer agent, dextromethorphan quinidine, which is the brand is New Dexta. We don't really know the mechanism for this. I found that, again, I look at these as fuse lengtheners. And so what we want to do is we want to lengthen the short fuse that these people have. Their tolerance of distress is very, very low. And so for reasons that we don't understand, this medicine also is worth trying. It starts once a day, and then we go to twice a day. It has 10 milligrams of quinidine in it. You all will scoff at that because apparently it's a pathetically low amount of quinidine. For me, as a psychiatrist, I'll check an EKG and make sure their QT is okay. Other mood stabilizers, fuse lengtheners, Lamictal or lamotrigine, carbamazepine, lithium, we also use as fuse lengtheners. And then we get to the bad boys of our world, the neuroleptics. We prefer that term to antipsychotic. And of course, there is this huge big black box warning, which will never be removed, I believe, because just no black boxes have ever been removed. That black box came at the same time that the Vioxx challenge, I think, occurred maybe 15 years ago, 20 years ago. The data is incredibly conflicting about what they euphemistically call an increased incidence in cerebrovascular adverse events. And of course, here I am saying this person with vascular dementia who has severe agitation, that is no UTI, has not responded to an antidepressant nor divalproex, needs a low dose of risperidol, 0.125, a whopping dose of risperidol, or a whopping dose of quetiapine, 12.5, and there's this big black box warning. In my experience, thank God, I've never really seen any cause for great concern. The concern for me is going to be, again, start low, go slowly. If you start with 0.5 BID of risperidol, if you start with 25, 50, 100 of quetiapine, I've seen that. If you start with olanzapine 10 milligrams, you're going to have side effects, probably, that might color any benefit that you would possibly see. It becomes a little more challenging if you've already identified that there's a pattern. So for instance, if there's a pattern of sundowning, as it used to be called, and we know that's our witching hour, risperidol, in my experience, is more of a laser beam. It's more of a focused medicine. And so if we needed a medicine from a timing point of view, that it's not just a general pattern of escalating agitation, but rather, no, 4 p.m., boom, that's our witching hour. My preference would be for a focused, sharp medicine like risperidol as opposed to quetiapine or olanzapine. And of course, you're going to monitor for extrapyramidal symptoms and Parkinsonism, which many people with dementia already have. People with vascular dementia in particular have earlier on symptoms of Parkinsonism than folks with Alzheimer's disease. There's a correlation, particularly with long-term use and higher doses with the metabolic syndrome. So we would like to monitor hemoglobin A1C and fasting blood sugar. Of course, you're familiar, we want to try our best to avoid these medications, although there are times, in a sense, paradoxically, that low doses of benzodiazepines are the only things that work. But again, I only get to them later in the game when everything else has failed. The storyline is that they can increase disinhibition. That's a double negative, but they can increase poor impulses or agitation. But that might not happen, and sometimes they really are effective, so they can be considered carefully. So again, non-pharmacological strategies. I mentioned children and animals. I mentioned music. I did not mention exercise. A brief play on exercise. To me, exercise is the most effective anti-anxiety, antidepressant that we have. So what's good for the heart is good for the brain. It's a good principle to remember. And as long as they're allowed to get aerobically moving, get them aerobically moving. We talked about the dementia unit. It's actually called Abe's Garden. You can look it up. It's in Nashville. That has really harnessed some pioneering ideas for dementia environmental architecture. Okay, I've spoken for my allotted time, I believe, and we're almost out of time. I apologize. I hope we have time for some questions if there are any. Thank you so much for your kind attention. I really, really appreciate your giving to us this hour of your truly precious time, and I wish all of you good health and to be well.
Thank you so much, Dr. Steinberg. If you want, you could stop sharing, and then they will see us in larger on their screens.
Stop share. How's that?
There we go. So, so we have a few questions. Some came up in the Q&A, some came up in the chat. We will not deduct CME credits for the people who couldn't follow the rules. So there's a lot of questions. I'm trying to find what that's most manageable. So one question is, what would you it has to do with kind of a hospital setting. Is there anything in particular you would do for hospital older person with dementia and, agitation, whatever it might be, presumably delirium without just from environmental change? Is that different? Would that be different than you would do in the hospital or in the office, or?
I think it would just be amplified, because by definition, the very reason they're in the hospital is probably a reason that they have to disprove delirium. So until proven otherwise, they're in the hospital, they have delirium. And then the question is, are there better choices for the acute management of agitation associated with delirium? In the office, we would try to avoid it and just treat the underlying cause. In the hospital, of course, that used to be called ICU psychosis or metabolic encephalopathy. It goes by all those different names. Everybody's searching for things. The general gist is that the higher potency antipsychotic medications, like in the olden days, Haldol or Risperidol, would be, in a sense, comparable, could be more effective than anticholinergically potent ones like thioridazine, of course, or like olanzapine, which has anticholinergic properties. So you'd want to avoid those and look at the timing as well and use a sharply focused one while you're treating the underlying cause, of course.
Great. And could you share any kind of site or specific resources that you give to family for education for behavioral modification?
I first and foremost recommend that everybody read the 36-Hour Day. It's an easy book to read, but not emotionally easy necessarily, but it really gives life to some of the defining things that we talked about today. And again, getting back to basics, that's really important, so that when they call you and say, Mom is hallucinating, you'll be able to say, are you sure it's not confabulation? And they'll know exactly what the difference between those things is. Of course, the Alzheimer's Association is a wonderful resource. There's out in Suffolk, we have day programs that are fantastic. We have Day Haven, which has 3 sites in Ronkonkoma. They have a site in Riverhead and Port Jefferson Station. They are intergenerational, which, as I said, children are important. So they have, well, pre-COVID, they have preschoolers, and the preschoolers come and join the seniors for activities. It gives such life to them. Nassau County as well has some good day program. I'm less familiar with those. Day program, probably one of the most important things I could recommend for outpatient family care.
Great. And someone shared that they had a patient with Charles-Bonnet syndrome who initially had good insight, but then later he started to have paranoia. So have you noticed any relationship between Charles-Bonnet and dementia or delirium, or is it purely because of vision loss and just not processing the signals right?
We actually don't know what the cause is of Charles-Bonnet. It's more common in people with visual impairment, but then again, most of our older folks have visual issues, glaucoma, cataracts, etc., retinal stuff. So that's a tough one. But the theme of Charles-Bonnet typically is that it was pleasant and it was engaging and it was colorful and it was animation in a sense. So I would be more concerned that something else is going on, or that maybe they didn't have Charles Bonnet to begin with, that maybe they were brewing vascular dementia, and it started with hallucinations that were pleasant, and then it just progressed alongside more confusion or more vascular events. Or that something else is going on in terms of a different kind of dementia to begin with. I know Lewy body disease is like the disease du jour, or soup du jour. I'm not entirely convinced that it's that easy to distinguish what the heck Lewy body is from vascular dementia with microinfarcts to that part of the brain. I think that Parkinsonism is a huge challenge, that people are diagnosed often with Parkinson's disease, who often have Parkinsonism from vascular events, and nobody's really looked at them cognitively until much later in the game. But if they did, they were fine. They were brewing cortical symptoms, which people with true Parkinson's don't get until very late in the game. So if you find cortical cognitive stuff in somebody with Parkinsonism, it's unusual for it to be from idiopathic Parkinson's disease.
It's a good point. It's so much overlap, and if you don't kind of tease out the history and the exam, you can label someone. Not that any of them are easy to treat anyway, but you want the right label.
One last point, if I can make, I really try to get my colleagues in internal medicine to get their medical assistants to consider cognitive testing a vital sign. You go in and they've already checked blood pressure and temperature and pulse. I mean, the person's there for a sore throat. Why on earth did they do that? But nonetheless, they do it. Well, why don't they do a quick cognitive screening? And because that way, then you'll know what kind of clay you're dealing with when you go in, and you'll know if you can inquire of the patient, or if you actually have to turn more to the daughter who might be with them to find out what's the valid response, the valid information.
That's true. There's two more quick drug-related questions, and then we'll stop. And thank you, everyone, so much for being here with us. So one is, if you use an SSRI for these kinds of behaviors, is there a time duration? Do you continue it indefinitely? How do you decide?
If there's a response, so if we have the time to afford a response, so we're talking 4 to 8 weeks, right? And so I would say if it's working and it's tolerated well and life is good, I would continue it. In depression, the argument would be 6 to 12 months for the vast majority of people, and then taper for depression. There are no clear rules about its use for these alternative reasons, we'll say.
Okay, and you had alluded to difficult levels, but can you clarify, someone asked if there's any value in still checking the level, even though you're not going to treat to a quote therapeutic level, is there value in checking it?
There's value in checking it, and particularly because we want to make sure that if they are developing symptoms that could overlap with side effects, stomach upset, tremor, for instance, I want to make sure that the level is not, the medicine is not the cause of it. So for me, checking a blood level, I just want to make sure it's within a safe range. People metabolize things differently, and there are drug-drug interactions, of course. So even though I may start with 125, and the poor man's rule is, if you really wanted somebody to get to a good Depakote level quickly, which I don't, it would be 20 milligrams per kilogram per day, would be like your guesstimate. But that's not the rule for our patients. I have had people on 250 milligrams who have a level of 75. And so I'm going to be really careful about titrating it if I need to. And if they're not responding by the time they're at that level, then I'm not really going to be that hopeful raising it's going to make anything different except make them more likely for side effects.
Great. All right. Well, again, Steinberg, thank you so much. This was great. Thank you to the 70+ participants who joined us tonight. I hope we continue to, I hope we get to be in person soon, but I really feel like the Zoom thing has opened up a world of opportunity, and I hope we could find a good way to do both moving forward. Loretta sent the link, so please get your CME credit. If you have any questions or concerns or ideas for future programming, please reach out to MAGS or NYACP. And again, thank you for, I'll say it, you're the best psychiatrist in Suffolk County. I'll say it. I'll say it on record. Of course, I haven't been there in 15 years, but you're the best.
You're so sweet and kind and everything. Thank you very, very much for this opportunity and your kindness.
Good. I hope the part where you said that nice thing about me was recorded too. I'll save that.
Nothing but the best.
All right. Thank you so much, everybody. Be safe. Be well.
Bye-bye.